Good morning. We're going over chapter 12, fluid volume and electrolytes. And so we're going to start off with homeostasis. Homeostasis, in biology, A&P, health science, we're talking about our body's own way of repairing itself in the healthy state, maintenance of the proper equilibrium, the intracellular fluid, extracellular fluid. So you want to look at an equal balance in the intake and output helps the human body maintain the proper equilibrium within the body systems. Intake and output of water is regulated by the kidneys and the pulmonary system by the hormonal and neural functions. Total body fluid is contained in two major compartments. In the intracellular fluid, and it's contained with the body's cells, and the extracellular fluid. It comprises of all the fluid outside the cells. And now the extracellular fluid is fluid divided into two components, and it's the interstitial compartment bays of surround the cell tissue, and the intravascular compartment contains the plasma, blood vessels. Transcellular compartment also contains the plasma, blood vessels compartment, also known as the third space that we've talked about. It contains the mucus, gastrointestinal, the cerebral spinal fluid, the pericardial, and the synovial and ocular fluid. Review the table in 12.1. Now, water that moves through the compartments of the body contains electrolytes. Electrolytes are substances that separate, dissociate into ions, charged particles that we all need in our bodies. So they are abundant in the interstitial and the extracellular fluid. Now, when we have a lot of diarrhea or we're dehydrated, those electrolytes get off balance. The ions carry either a positive charge, which is a cation, or a negative charge, which is an anion. And then many illnesses in the body system alters the electrolyte balance, like what I just said. And the major electrolytes in the body fluid are sodium, potassium, calcium, magnesium, chloride, phosphorus, sulfate, hydrogen, bicarbonate, ions, and many proteins. A lot of this is just going over what we learned last semester. So you want to just continue to know how important this is. Administering intravenous fluids will help with that. If you're dehydrated, it helps with the electrolyte replacements. It may be thought as routine nursing care. However, it requires much diligence to make sure, and critical thinking to see and administer any type of drug, because you remember how the crystalloids and the different types of fluids that you give people that have had different situations. Two principles that stand out considering the homeostasis is the fluid and electrolyte balance is the principle of the anions and cations. Much balanced within each compartment that remain electrically neutral. The second principle is the fluid compartments remain in osmotic equilibrium, because the movement of the fluid and the particles between the compartments is controlled by a number of processes, including osmosis, diffusion, hydrostatic pressure, osmolarity, and active transport. Now, y'all have heard this before. Needs to be embedded in your brain because all this is going to repeat itself throughout your nursing career. You want to know these things and these processes. These are the fundamentals that you have to know. Now, your osmolarity refers to the number of particles dissolved in the serum, primarily sodium. Sodium's the number one, and then the urea, which is the blood urea nitrogen, and the glucose. You're going to always see this on the CBCs and the CMP and the BMP blood panels that you're going to have to look up and report to the physician. And the glucose, it's the measure of the concentration of the solutes per the kilogram in urine. It's going to be measured in the urine. And when they want you to do a UA on the patient, sometimes it's going to be straight cath, which you're going to be, you have to know, male or female, you're going to have to in and out cath like you would when you did skills for Foley. So you have to know the normal serum level and the osmolarity and how it ranges from usually 275 to 295. So then you have the fluid has the same weight proportion of particles in water. Hypomolar is fluid that contains fewer particles than water. And then hyperosmolar is fluid that contains more particles than water. Okay, so hypo always means fewer, hyper always means more. Tonicity is the primary a measurement of the concentration of IV solutions comparable to the osmolarity of the body fluids. Now you'll have all different types of route. You can have oral, you can have IV. There's preferably every physician, if they can drink oral, it's preferable. But if they come in severely dehydrated and they haven't been drinking things orally, then you have a 3+ ketosis on the urine dipstick. You want to push the fluids. So you're most likely going to start an IV and give a bolus. All routes of fluid intake and loss must be considered when assessing the fluid balance. So if you're putting a liter of fluid in and they still haven't voided within 2 hours, and when they void, it's still concentrated with an amber color, and you dipstick that again, and it's only gone to 2+ ketones, they're severely dehydrated. So you continue to bolus, with the report back to the physician. So you have to use your fundamentals and know, because you're the one that's between the patient and the doctor. And so you have to know your skills. The recommended water intake for a healthy adult is 2,300 to 2,900 milliliters a day. Tell us how many of us do that. But you have to consider it's not only through water, it's also through fruits, different things that we eat. Vegetables have water in it, but we have to make sure we're getting the adequate amount of water. Patients lose water through various routes: kidneys, skin. If we're out in a hot weather and we're sweating, we're having a risk for dehydration. We're breathing off through our lungs and our GI tract. We're having water goes out in so many different areas. Sensible water loss through the lungs respiration is usually 500 milliliters a day. Perspiration, skins 500 to 600. You see some people that really perspire, they need more fluids. Then so the GI tract, depending on the patient, does that patient have a history of increased diarrhea or increased issues with the GI tract? So, you have to know your patient. The minimal urinary output for the patient, for an adult is 0.5 to 1 milliliter per kilogram. It's basically 35 to 70 milliliters per hour. And the minimal is the 30 if you're looking at in a critical care situation. If you're not getting that, something's compromised. So you're going to have to look at your protocols for hypovolemia. If you don't catch that, shame on you, because there are so many people that have been overlooked, and because of the fact patients up voiding, or they think they are, and it hasn't been measured throughout the day, and they end up finding out they're hypovolemic, and they go into issues because they may have come in with heat stroke, and because of the shutdown, they go into sepsis. So IVs are ordered based on the evaluation of the patient's fluid and electrolyte balance, fluid requirements, and fluid needs. And now we have the types of IV solutions like we've talked about last semester. We have the crystalloids, which is the isotonic, hypotonic, and hypertonic. And then we have the colloids, and then, of course, the blood and blood products and the lipid emulsion. Now, the isotonic solutions have the same approximate osmolarity as your plasma. They're primarily used for hydration and to expand the fluid volume. So with your hypotonic solutions, they have less osmotic pressure, so which follows water into the movement of the cell. So excessive infusion of hypotonic solutions may cause hemolysis. So if a person's super dehydrated, what would you use? Start thinking that way. Decreased blood pressure and decreased inner fluid volume. And the hypertonic solution exerts greater osmotic pressure to the the actual extracellular fluid, resulting in a higher solute concentration than the serum. Patients receiving the hypertonic solutions must be monitored carefully for signs of circulatory overload. So you're going to, if you have more sodium on the extracellular, it's going to pull fluid outward. So therefore, you have to look and make sure there's not a increased fluid volume to their feet. You want to make sure everything is balanced. Parental volume containing dextrose, available for concentrations and combinations of solutions such as normal saline or lactators ringers. Dextrose solutions provide hydration for some calories and increased glucose levels in the blood. Say, for instance, if a person comes in with throwing up coffee ground emesis, they have definitely could be having issues with either blood in the GI tract, or they have a potential blockage. You want to make sure they're receiving the dextrose to give them their nutrition, and make sure that it's not too high. because dextrose solutions higher than 10% should be given only in the central vein. An excretion of 50% dextrose, which is most given in small amounts, with the we call it PIV, the peripheral vein, is best with hypoglycemia. We got the crystalloids, and here are some of the examples. Colloids, which basically are volume expanders. Balanced electrolyte solutions, like LR, contain electrolytes, but they don't contain magnesium. They're minimal caloric and additional of dextrose. Their primary use is hydration and electrolyte replacement. However, they do not provide the adequate electrolytes for maintenance therapy for patients with limited or no oral intake. Colloid solutions contain a protein or other molecular substances that increase the osmolarity without dissolving the solution. Now remember, before we get into this blood products, just the colloids increasing the pressure is pulling fluids from the interstitial space into the plasma, increasing the blood volume. So for instance, if you have someone that's bleeding out, you want to use a colloid. Blood products include packed red blood cells, plasma, and the just the cryptopeptide. And so it is important for nurses to understand the specific components prior to beginning the transfusion. Even though you're an LVN, you can be involved in this, and the proper product to the patient, the identification, is paramount in preventing any kind of transfusion reactions. So that's why you always have 2 RNs witnessing and 2 people witnessing, and you have the temperature taken before you start and 15 minutes once you get in to the blood transfusion to make sure you don't have any reaction. The maximum rate is 4 hours per unit. You don't want to go and be any slower than that. Beginning with the removal of the unit from the refrigerator. Now, with loop diuretics, you're wanting to prescribe the patient receiving whole blood products and packed red blood cells to prevent the circulatory overload. So with the patient with the fluid imbalance, you're going to be looking at your care plan again. And so you want to start thinking in those terms. In your nursing process, you got the fluid imbalance, the assessment, the nursing diagnosis, the nursing process, which is the planning, nursing interventions, your evaluation. So you'll be looking at, for your objective data, you have your electrolytes, your potassium, sodium, all your different electrolytes, and you want to have a baseline, what they started with, and then a redraw to make sure that they are achieving their goal. Now with the potassium, the major intracellular is 98%, and the body's potassium is found within the essential for neuromuscular activity and cellular metabolism. Potassium levels affect the cardiac and the skeletal muscle activity. So we always hear about the leg cramps. If you're dehydrated, you're going to lose your potassium. A lot of people recommend the pickle juice or something that will help start those imbalance to be balanced out. And your levels of potassium, you got 3.5 to 5. And you know, the higher it is, the more dangerous. You have to really watch your potassium levels, and you can have a false positive or increased on dehydration because of the fact it has less fluid volume. You got hypokalemia, less than 3.5, and look at the signs and symptoms of that. And then you got the hyperkalemia. Hypokalemia occurs, and in most cases, they are caused by excessive loss rather than the deficient intake. And then with the hyperkalemia, you have usually with the excessive intake, impaired renal excretion. It's not throwing off the potassium properly, or a shift in the intracellular or extracellular space. You have potassium wasting diuretics, which we have the Coumadin that you have to supplement the potassium with. And we have talked about how we have to make sure we're educating the patient, because this is where your diuretics will incur patient safety. Because you have the fluid diuretics, which is potassium wasting, and then you have the potassium sparing. And the sodium is a major cation, the serum sodium. Here's some more information about the potassium. When you're given potassium, make sure you give at least 8 ounces of water. Changes in the ECG also. You'll see if you're imbalanced in potassium, you'll see changes in your EKG. Now, here's your sodium level we're talking about. Sodium levels less than 135 they're usually called a low sodium. And you got hyponatremia, and you look for the signs and symptoms for that and the correction. And so then the hypernatremia, and you look for what the types of food those patients are eating, and also the renal function. Because a patient that is actually compromised secondary to hypertension, they're going to be compromised. Their renal system is going to be compromised, so they're not going to be filtering the sodium out. So they're going to actually be third spacing, and so it's going to be pulling fluid on the extracellular side. Now, when we're talking about hyponatremia, you're looking at the thirst, some of the symptoms, and then also, the symptoms will depend on the onset, and when it happened or what happened to them. Some could be secondary to brain injuries, cerebral spinal fluid loss. It could be they could start having confusion, seizures, secondary, going into a coma-like state. Hypernatremia can cause a sodium gain, sodium retention, or a sodium water loss. Calcium, we're going to talk about next. And we're also looking at the nursing process every time we're doing this, because we always have to correlate the problem with a solution. So this is always think nursing plan. With the calcium, it's found approximately equal the proportions in the interstitial fluid and the extracellular fluid. A calcium deficit less than 4.5 is called hypokalemia, and then the calcium of the excess of 5.5 is called hyperkalemia. You're looking for signs and symptoms of severe hyperkalemia. You start having laryngeal spasms and twitches of the mouth. Over 90% of the body's calcium is found in the bones and the teeth. Of the remaining calcium found in the blood, about 50% is bound to protein. Calcium, you got to look at the nursing process here. Calcium promotes a normal nerve and muscle contraction. If you get twitches behind the knees, you take calcium sometimes when you're deficient, and it will help the spasms in the muscle. Cation maintains more cellular permeability and promotes blood clotting by the converting of prothrombin to thrombin, calcium into the needed formation of bone and teeth, and calcium levels are regulated by the parathyroid hormone and the calcitonin. Just always think nursing process with any issue you have in your body. And if you think that way, you'll start working that way. And it's a good way to treat the patient. One thing I want to start saying is the magnesium, but before I go on with the magnesium, I want to talk about the vitamin D and how it's needed when you're absorbing the calcium in the GI tract. You're going to see that again. Just remember, it is needed with the calcium absorption. And when you have an calcium intake, it causes calcium to leave the bone. It actually pulls it out into the serum. And then because of the calcium loss from the bones, and you'll see that a lot in pregnancy, when the fetus needs calcium, it'll pull from the mother. And so you have the bone demineralization and pathological fractures, and you'll have teeth issues. May occur if calcium deficits persist. And with patients' renal functioning, it should be assessed before administering IV. You're also, when we're going in to talk about magnesium, we're going to talk about how calcium and magnesium counteract each other. Now, elevated serum calcium can be a result of the hyperparathyroidism, malignancy, hypospasthemia, excessive calcium intake, prolonged immobilization, um, which can also lead to blood clotting, just basically multiple fractures. The actual drug such as the thiazide, diuretics, and steroids. Now getting on with the magnesium, it's um, it's plentiful in the interstitial fluid. Magnesium deficient often occurs in the hypokalemia and the hypercalcemia. The normal serum magnesium levels are 1.5 to 2.5 milliliters. Equivalent are 1.8 to 3 milligrams per deciliter. And then the magnesium promotes transmission of the neuromuscular activity to the important mediator of the neurotransmission of the central nervous system. And we'll see it activates many enzymes in the metabolism of the carbohydrates and the protein responsible for the transportation of sodium and potassium across the cell membrane. You'll see a lot of issues with people that have digestive issues that have deficiencies in magnesium. And with the low magnesium, it actually causes an increase of release of the acetylcholine from the presympathetic membrane of the nerve fiber, which increases neuromuscular excitability. And so you'll see increased peristalsis of the smooth muscle. And then the hypermagnesium will have a sedative effect. That's why they give it to patients in preterm labor, or actually patients that are having increased hypertension when they're pregnant. So if you have a really high magnesium level, it can actually have that sedative effect, and you'll have a loss of the tendon reflex, where if you have a lack of it, you'll actually have an increased deep tendon reflex. So therefore, you want to think in the process of the magnesium. So assessment, check the serum magnesium level, assess the signs and symptoms, look at your nutrition balance and what you do and what your goals will be, and how you'll plan to intervene and how to educate. And so you want to evaluate your goals and see if anything needs to be modified. And then you will go and recheck and see if everything is improved. Now your chloride is the principal anion of the extracellular fluid. The chloride ion is a major contributor in the acid-base balance in gastric juice acidity, and then the osmolarity of the extracellular fluid. Normal serum chloride are 96 to 106 milliequivalents per liter. Now, clinical manifestations of hyperchloremia includes tremors, twitching, slow, shallow breathing. So you just want to make sure that you're always assessing the patients overall. Clinical manifestations are hyperkalemia include weakness, lethargy, deep, rapid breathing, eventual unconsciousness. And here we got our phosphorus is a primary anion of the interstitial fluid, and then is the second most abundant element in the body. But remember, you don't want too much of it. Yeah, this is what the kidneys filter. You don't when you have renal dysfunction, we have to watch how much phosphorus our body takes in, because it can have a phosphorus overload. So a normal serum phosphorus level is 2.4 to 4.4 milliequivalents per liter. Both phosphorus and calcium levels are regulated by the parathyroid hormone and need vitamin D for absorption from the GI tract. So when we have too much phosphate in our systems, it's going to pull the calcium. So it's going to cause low calcium levels. Then the low calcium levels will stimulate the release of the parathyroid, which decreases the reabsorption of the phosphorus. So it's just a domino effect. Clinical manifestations of the hypophosphatemia include muscle weakness, tremors, bone pain, hyporeflexia, seizures, hyperventilation, anorexia, and dysphagia. Symptoms of the you have to really make sure that you're not, all this can relate, and they're similar to the hyperkalemia, and it includes the hyperreflexia, tetany, positive signs of the cerebral pedal spasms when you do the foot Babinski, and the twitching of the facial muscles to the tapping over the facial nerve, and the flaccid paralysis muscle, weakness in the and then tachycardia, nausea, diarrhea, and abdominal cramps can all be a sign of too much phosphorus in the system, which can also indicate a renal dysfunction. Just go over your practice questions, use your study guide, all the resources you have available, and be prepared for your exam.